In the RESPONSE trial, those patients required a phlebotomy, to be eligible, required phlebotomies and had to have splenomegaly. And some have criticized the study by saying, well, that's not really a goal of my therapy in most PV patients. But there is data looking at patients who don't have splenomegaly in the RESPONSE-2. Rami?
Right. So the RESPONSE-2 was like similar design to the RESPONSE-1, but in terms of the eligibility, there was no requirement for spleen enlargement or splenomegaly. So in the RESPONSE-1, it was a composite endpoint looking at spleen response as well as adequate control. In the RESPONSE-2, the study had patients that were intolerant or resistant to Hydrea. They were randomized between best available therapy or Ruxolitinib. And the primary endpoint was looking at adequate control of the blood count. And the study was presented originally and updated later on with showing durable responses in the range of 40% plus with adequate hematocrit control. And I think importantly, again, symptom control in more than half of those patients. So definitely the value of the Ruxolitinib in patients with P-vera is not just for the spleen reduction. I think it's for the count control. There is subset also of patients, around 20-25% of the patients, that will achieve a complete hematological response where they normalize their other counts. I think splenomegaly does happen. We observe it, as you mentioned earlier. Most often, it's not relevant symptomatically for the patients. Early in the disease, it may be later on to be an indication for treatment, but other symptoms, as mentioned, for example, itching and constitutional symptoms are probably more prevalent. So the RESPONSE-2 nicely shows that, the goal of the treatment it was not just control of the spleen, but actually it provides count control and symptom improvement, which is, again, very important for those patients. So.
Right. And I know we've gone through the cyto-PV showing the importance of hematocrit control, the data for white count control. But is there actual data with Ruxolitinib that we're doing what we talked about at the beginning, and that is decrease the risk of thrombotic events?
Right. So that's a very interesting point you raise, and I don't think it had been looked at as a primary endpoint in those studies. But if I recall correctly, in the RESPONSE-1, it was reported almost like in the side effects thing, and the events were a little bit less with Ruxolitinib than with Hydrea, in thrombotic events. And Ruben may correct me if I'm wrong.
Sure. So it was not one of the primary endpoints, and I think it's a reflection of, the rate of events would have just not been practical in terms of the study. But in terms of the trend is very significant. That there clearly are, many fewer events on the Ruxolitinib treated patients versus those that receive best alternative therapy. And there are a variety of reasons to really, believe that data. First, the better control in the counts, but second, the decrease in the inflammatory milieu, which likely is contributory to a prothrombotic state, is really improved. So I think there's definitely that expectation that you're helping to decrease that rate of events.
And also, in terms of the side effects, when we mentioned the skin malignancies, I think that's an important point to keep in mind for all patients with MPN, because I think they are at a higher rate. But even in those studies, when you look at the Ruxolitinib versus the Hydrea, I think the rates were higher with Hydrea still than with Ruxolitinib. But it's an important point to keep in mind for all our patients that they need those annual checkups, and but I don't think the rate is higher with Ruxolitinib than Hydrea. So.
Yes, as I remember, if you put both RESPONSE-1 and RESPONSE-2 together, there were numerically more thrombotic events with best available therapy. But of course, the study wasn't powered. And it's a very short follow-up, right? It was 32 weeks was the time of the primary endpoint. And clearly, this is a chronic illness. I think one of the nice things that we've seen from the long-term follow-up of RESPONSE-2 is that patients are staying on therapy, suggesting that their disease is controlled, actually. And they did show that.